So next we have Marianne Jackson. She's a 1978 graduate of the UMKC School of Medicine. She completed a pediatric residency at Cincinnati Children's and infectious diseases fellowship at the University of Texas Southwestern before joining the faculty at Children's Mercy in Kansas City in 1984. A fellow of the American Academy of Pediatrics, the Infectious Disease Society of America, and the Pediatric Infectious, and the Pediatric Infectious Disease Society. She served from 2017 to 21 as a member of the National Vaccine Advisory Committee. Dr. Jackson is a professor of pediatrics and was dean of the UMKC School of Medicine from 2019 to yesterday. She is the author of more than 375 peer-reviewed abstracts, publications, and book chapters on topics related to infectious diseases, epidemiology, clinical presentation, diagnostic treatment, and prevention of communicable diseases. Starting March 11th, 2024, she continues at UMKC as Special Advisor to the Chancellor on Health Affairs. And I have listened to her many times on Steve Kratzke's show talking about getting us through COVID, so she didn't even mention that. Are you good? You got that one.
I'm good with this.
Yep.
Is that okay? Good afternoon, everyone. I am delighted to be here with you today. So I'm a pediatrician. I'm a pediatrician whose specialty is infectious diseases, and I've spent my entire career since 1984. I've been faculty at my clinical home, which is Children's Mercy Hospital. My educational focus has been on the diagnosis, treatment, and prevention of communicable infections. And so it was, I guess, fortuitous that as I started my deanship, that we embarked on a COVID pandemic, and it allowed us to actually navigate through the challenges educationally for our students, perhaps more easily, because the principles of public health are the principles of public health, and we were able to move forward in a very positive way. I mentioned that from 2017 to 2021, I was a member of the National Vaccine Advisory Committee. So there are about 15 physicians from around the country who joined this committee that prepares the vaccine recommendations for the country. The Surgeon General gives his orders to the Assistant Secretary of Health. That individual gives their orders to us as part of the National Vaccine Advisory Committee. And so it's an interesting time to be part of that committee because of the political agendas there, which were to more actively investigate vaccines that had been deemed safe for decades. And we were able to move that forward. We created white papers on a number of different vaccines that were out at that time, including HPV vaccine, started the deliberations on COVID vaccine, and then that committee has moved on to create the recommendations on RSV vaccines. So respiratory viruses are important, and I initially was going to talk about RSV, but it actually is waning at this point. I can tell you that if 100 children showed up right now at Children's Mercy with respiratory symptoms, there would be 3 out of that 100 with COVID. There would be 3 with RSV. There would be 45 with influenza. So influenza is still the most common virus that's circulating, and it is influenza B. And just to give you an idea, last week at Children's Mercy Hospital and the week before, if we combine, more than 600 children diagnosed with influenza. So it is still very prevalent. However, what we're getting into now is tick-borne season. And tick-borne season is important, and I'll explain why here in just a second. Okay, so here we go. So one thing I'll let you know is AI is here to stay, right? Everybody's heard about it, and you're wondering what it can do for you. And I've played with it just a little bit. So I went on ChatGPT And I told them that I would be talking with y'all today about tick-borne infections. And I said, the title of my talk is Tick-borne Infections, which is kind of boring. Can you create some different titles for me? And literally within 5 seconds, I'm not kidding, within 5 seconds, it gave me 8 different titles that I could choose. And none of them seem and tick-borne infection. We obviously don't have any types of disclosures to make to you today. So we're going to talk about the most common tick-borne infections that will affect you here in this part of the country, or you if you are a traveler. We're going to talk about Rocky Mountain spotted fever, Erlichiosis, Tuleremia, and Lyme disease. And we'll talk about the disease itself, the illness that it causes, and the mortality that it causes, and how we diagnose and treat. So there are a lot of ticks out there. And in fact, back about 2 decades ago at the University of Missouri in Columbia, there was an investigator who took burlap out and collected thousands of ticks. And it turns out there are, it sounds like a fun, no. And out of the 1,000 ticks that they collected, there were a variety that they found in our part of the country. And the most common ones were the black-legged, or was the Lone Star tick, the American dog tick, and the Rocky Mountain wood tick. We really see very little of the black tick that causes Lyme disease, and I'll tell you why that later. But here's the important thing to know. Of that thousands that they collected, only 3% of the ticks carry a germ. And so most of the time you can get a tick bite and you're not going to get sick. But if you do get sick, it can be life-threatening. So of the tick-borne diseases that I'm talking about today, I've shown you a map of the United States. And one of the things that I want to draw your attention to is if you look at the state of Missouri and Kansas, and you look at Erlichiosis, Rocky Mountain spotted fever, and Tuleremia, you see that we are well represented in our part of the country. If you look at Lyme disease, you notice that Missouri and Kansas are blank. There is not Lyme disease in our part of the country, but if you're a traveler, you could encounter it. And so that's why we're going to talk about it today. So what's all the fuss? This came from the CDC back a few years ago, and that's a poppy seed muffin, right? And then if you look at the enlargement of the poppy seed muffin, you see ticks. That's how tiny they are, and that's why they're often missed. We'll first talk about Rocky Mountain spotted fever. So this is one of the most deadly of the tick-borne diseases that we see in this part of the country. The infecting agent is a bacterium called Rickettsia, and dog tick and wood tick, and primarily are the vectors for this infection. There's another Lone Star tick that causes a disease that's similar to Rocky Mountain fever, but the dog and wood tick are most common. It usually takes several hours of attachment for the tick to transmit infection. That means if you come inside, do a tick check, and remove ticks within hours, even if it is an infected tick, you will not get sick. So it's the second most commonly reported tick-borne disease in the U.S., but the tick bite itself is only recorded in 50%. And so if somebody comes and says, I have a fever and look at these spots, and I had a tick bite a week ago, well, you can put the information together pretty quickly, but that's not the case many times. So what, as pediatricians, as adult providers, what we ask is, have you been anywhere with tall grass where ticks live? And if you think about where ticks live, they live in the branches of those little bushes there. So when you're walking, if you're a person who likes to hike, if you're walking on a path, you want to walk straight, not on the edge of the path where you're going to encounter ticks. So is a map of the United States in the upper left. And what you see, the darkest part of the country, the darkest purple, are the most cases of Rocky Mountain spotted fever. And what you notice is Missouri and Kansas, smack dab in the middle of it. Then on the lower right-hand side, these are the months of the year where we see this. And it turns out that there's a peak as we get into the summer season. But what I want to tell you is this: ticks come alive as soon as the temperatures hit 50. And with global warming, we're going to see more tick-borne diseases in our future. I mean, right now, I think if you're out and about in the tall weeds, you may well encounter ticks even this part of the year. So, tick-borne infection that has an incubation period of about a week. The classic triad is fever. It's high fever. It's not low-grade fever. It's fever of over 102. It's rash with tick exposure. So you put all that together and you usually have the answer. But here's the important part of this. The rash is not present in the first 3 days. And so it's fever, malaise, headache. It looks like any other viral infection and has a very long differential diagnosis. And so you can miss it during that period of time. Plus, where it hides out until it becomes very, very evident is on the wrists and ankles. It can be on the palms and soles. Unless you look there, you will not find it because it starts out as just little macules, little red dots, and then it becomes petechial, which petechiae are broken vessels, for instance, and they do not blanch. So most patients have fever and headache. The severity ranges from mild to life-threatening. You have 5 days to make this diagnosis. In the child population, where fevers are pretty common, and fevers that last 3 or 4 days, not unusual, this can be, and children can die from this infection. In fact, deaths are most common in children under the age of 10. In the adult population, we see Rocky Mountain spotted fever too. But if you have a fever of 102 with fever and other clinical symptoms, you get yourself to the doctor pretty quick and they start thinking about the differential diagnosis. And once you get into day 2 and day 3, if you have a good doctor, they're going to think of this diagnosis, particularly if they ask you the right questions. Where have you been? What have you been doing? So photophobia, muscle pain, nausea, vomiting, and abdominal pain. And this is a vasculitis, meaning it's inflammation of blood vessels. And so this is part of the reason that this is so life-threatening, because it can involve the brain, it can involve the heart, it can involve the blood vessel system, so you can have bleeding with this, it can involve the lungs. So there are ways to make this diagnosis. As you might guess, there are a lot of children in the summertime who have tick bites, especially if they live in rural areas. And I had one mama one day, and she had 6 children, and she came in to see me, and she brought in George. And George has had a fever for 2 days. And I said, has he had a tick bite? And she opened her purse, and she pulled out index cards. Every child's name was on an index card, and every time she took a tick off, she taped it to the card and wrote the date. So she could tell me quite precisely, we don't recommend this. This was what happens when you have 6 children. But the children come in during the tick-borne season, and if they have been in areas where they could have been tick exposed, there are 3 different tests that I look at very carefully. I look at their white blood cell count, I look at their hemoglobin and platelets, so that's a CBC. I look at their serum sodium, and I look at liver functions. And there are often clues that come on very quickly with this. So within the first 48 to 72 hours, when I see low platelets and low sodium, I'm thinking tick-borne disease. And what you need to do is you need to make the diagnosis empirically and start treatment immediately. And the treatment of choice is doxycycline, which is not a drug that is typically given in the pediatric population. It has about, of all the infections that we have, the hundreds and hundreds of infections, this is the drug of choice for probably 10 or 12, but all the tick-borne infections. So antimicrobial therapy immediately, and not wait for a diagnostic test, because the diagnostic test is antibodies. They don't form until 7 to 10 days. When do you die? Day 5. So patients with suspected Rocky Mountain spotted fever, they receive doxycycline immediately. It used to be thought that it stained the teeth. And so there was always this conundrum, what to do with a child under the age of 8 who had Rocky Mountain spotted fever. But what we found, and we found this really in the last 5 years, is there's no staining of the teeth with doxycycline. It is a completely different compound than
tetracycline in terms of its binding dental enamel. So the other piece that's important about this is if you believe you have a patient with Rocky Mountain spotted fever and you start doxycycline and they are not better by day 3, you better be thinking of a different diagnosis. There are certain drugs that worsen the outcome, and the sulfa drugs are on that list. So there's a 2 to 4% case fatality, and the delay in initiation of the treatment is the biggest risk factor for death. And for those who are untreated, most die. The delays occur when patients fail to consider the diagnosis. And the factors that I think are most important is the lack of tick exposure, the presentation during the first 3 days, the non-summer presentation, and the lack of rash. And you can see spotless Rocky Mountain spotted fever. So here are the pearls. The name is a misnomer because it can occur almost anywhere in the United States, but we are the prime territory. The common months are April through September, but it can occur anytime. The only month that usually doesn't occur in, if you take a guess, is December. Absence of rash never excludes the diagnosis, and the signs and symptoms are non-specific. And so doxycycline is going to be the drug that you're going to remember for almost all of these infections. So next, we're going to talk about ehrlichiosis. Ehrlichiosis is more likely to impact one of you in this room, maybe than Rocky Mountain spotted fever. It is a common bacterial infection. There are a variety of different pathogens, but Ehrlichia shaviensis is most common. And there's small little gram-negative cocci that invade white cells. So you see the arrow on the white blood cell that's in this picture on the left? It is pointing to the gram-negative cocci that is Ehrlichia that's inside of a white blood cell. So when that does occur, you can actually make the diagnosis very quickly. So, and one of the most interesting studies that was published about ehrlichiosis was in 1993, and it occurred in Tennessee. And 4 men in the same community developed headache, vomiting, abdominal pain, and fever. And they actually confirmed this when they investigated the outbreak. And they found that the risk factor for these 4 men were that they had many tick bites, that they did not use insect repellent. Their average score, you notice it's greater than 100. They weren't very good golfers. And they all chased after their lost balls. So they were all in the areas where you would find ticks. And so we learned a lot from that outbreak that occurred. So once again, there's the map. And once again, you see Missouri and Kansas, dark purple. On the other side, you notice here that there is an increase in the cases of ehrlichiosis in the U.S. It's probably because we think about this diagnosis more often and are able to confirm it more often. So again, April through September is prime, but I mentioned here that as we have these warm days now, the ticks are going to come out, and unless we have an extended freeze, they're going to remain out. Most patients live in rural areas, but you can develop ehrlichiosis right in your backyard, even if you live in a rural part camp. The incidence is likely underestimated, and this is a study that it's probably at the bottom there that you can't see, but about a decade ago, maybe a little longer than that actually, there were 7 ID doctors, and I was one of them. All of us represented an area where ticks were common, and we actually did a seroprevalence study. And so what we did is we collected blood, leftover blood from children in the non-Ehrlichia time of the year, and that would be after October and before March. And what we found were 12.5% of 2,000 children, those are all the children we collected blood from, had a positive antibody titer. We realized it's likely more common than what we were thinking. There's an age-specific incidence, and it's greatest, this particular infection is greatest incidence in those over the age of 40. And it's probably, for those of us who like to get out and hike, maybe golfers, but more common than in the child population. Most children have a tick bite history, versus Rocky Mountain spotted fever. And it has a little bit longer incubation period. So for those who do have a tick bite, I can ask them, when was your tick bite? And oftentimes it's specifically recalled, and then you can use that incubation period to think, is this Rocky Mountain spotted fever or Erlichiosis? Because the symptoms really overlap. Fever, rash is less common, but looks pretty much the same. Headache, muscle aches, malaise, cough, vomiting, confusion. It is not a vasculitis. And as I mentioned, the rash that we see can be a variety of different factors, just like Rocky Mountain spotted fever, on the trunk but on the extremities commonly. It can be severe if untreated. One thing that's really interesting about this particular entity, it can be mild, but it can lead to liver failure. And back a few years ago, we had a child who, this was before Children's Mercy was doing liver transplants, University of Nebraska was, and we had arranged transport for that child to the University of Nebraska for a liver transplant because of liver failure. But we saw the child about 24 hours before that transfer was occurring and started doxycycline. By the time the child got there, their disease was resolving and fully resolved, in fact. So it's a unique feature of Erlichiosis. Early signs and symptoms, non-specific. It can look like a virus, intraviruses, monovirus, CMV. It can look like Rocky Mountain spotted fever. It can look like bacterial sepsis, and sometimes that's something we think about and treat at the same time we're initiating treatment for Erlichiosis. Again, the low white blood cell, low platelets, low hemoglobin, low sodium. But you notice that I mentioned the liver dysfunction is quite uncommon factor there compared to Rocky Mountain spotted fever. In contrast to Rocky Mountain spotted fever, there is a PCR that we can do. If it is positive, it is diagnostic. And so it is helpful and it is immediate compared to the antibody studies, which again, you have to wait 7 to 14 days and you do not want to wait. Again, treating based on history, exam, and laboratory features. Again, it's doxycycline. Again, the patient should respond within 48 hours. If they don't, think of a different diagnosis. So now we're going to talk about tuleremia, which is interesting for a number of different reasons. So this is caused by the bacteria Francisella tularensis. It is a small, non-motile, gram-negative aerobic coccobacillus. There are a couple different biovariants, one more virulent than the other. It is transmitted in a number of different ways, most commonly in children by ticks. It can be, though, from bites or direct contact with other infected animal tissues. And you can see the 100 species, more than 100 species that could be involved. And there are even cases where rabbits are infected and somebody mows over them and they inhale the pathogen and develop pneumonia. So that is something that we think about. But we also think about this as rabbit Skinner's disease. And so they that have an infected animal and may cut themselves after they're skinning an animal. And we see that transmission as opposed to tick-borne. Between 100 and 300 cases annually. It's the third most commonly reported tick-borne infection. The Midwest, of course, highly represented once again. It is highly, highly contagious. As few as 10 organisms can infect the humans through skin or aerosol. And it's really important because this is a biohazard. So it is something that we can culture, but we do not want to culture it unless we can have the safety of our laboratory tissues, because one of the things they do, and I'll show you the next slide, it grows on a plate. And one of the things that microbiologists do is they smell the plate to narrow down the differential of what it could be. And so if they are not thinking about tuleremia, and this looks like a very common pathogen called Haemophilus that does grow on the plate and looks similar to it, the microbiologist can become infected and develop tuleremic pneumonia, which is very, very serious. The tick-borne infections, though, most common in those under the age of 10, and those are again over the age of 50. So you can see why I chose to talk to you about this. Most cases occur June to October. It does not occur person to person. The incubation period can be quite long. And when we looked at this carefully, what we found is that the average child had 3 or more visits and got 3 or more of the wrong antibiotic before the correct diagnosis was made because people didn't think about it. But I'll show you what it looks like and why it should be easy to spot. Okay, once again, you can see Missouri and Kansas were well represented. And then once again, you can see been somewhat of a decrease in the cases, and probably represents the things that we've done to make the outdoors safer. So this has 3 different forms that we see. The most common that we see is called ulceroglandular disease. And that means at the site of a tick bite, an ulcer forms. And the lymph node that drains that site also becomes involved. But as you might guess, in children, where do you think they get their tick bite? On their scalp. And so people don't think about looking on the scalp for the ulcer, and all they see is the lymph node. And there are a lot of different reasons children develop lymph node involvement. It presents with fever and chills, headache, myalgia. The ulcer at the tick-borne site does not heal. So if you hunt for it, you can find it. And depending on what it looks like, you can make that diagnosis very easily. So here are 2 cases of children that we diagnosed. On the right hand side, this is a baby, and you can see that ulcer at the tip site, and you can see how that has grossly enlarged over time. But you have to be able to think that this ulcer is related to tuleremia in order to make the diagnosis. The other child that was a patient that I saw in 2008, I like this case and I show it because it shows the value of asking a grandparent for their input when you're seeing the child. And so this is a child that got treated 4 different times for this swollen lymph node in the groin area. It was drained, it never got better, it kept coming back, the child did not do well. Finally, they admitted the child to the hospital and got an ID diagnosis at that time. And so I went to see the child, and I'm thinking, okay, so this lymph node has not improved for over a very long period of time. And I was actually just trying to stall for time as I was thinking it over. And so what I asked was, what is next to the belly button? And the grandmother said, oh, that's where she had a tick bite a month ago. And so very quickly we could put the diagnosis together for this child, and very quickly she got started on the right drug and got better. Pneumonic tuleremia, I mentioned that it can occur after mowing over rabbits, but it's most commonly encountered in the laboratory, and I told you why. The symptoms are localized to the respiratory tract, and I show you an X-ray up at the top. The radiographs can show a variety of different types of pneumonia. There's not a specific type that's most common. But one of the things that we've learned is that this is a bioterroristic agent. And so there has been concern that there could be instances where this particular organism could be released. And so if you see more than one case in an urban environment of tuleremic pneumonia, you think about it being a bioterroristic event. Meningitis does occur with this. So again, is lymphadenopathy during the summer months. Think about it. The tick exposure history, it's not excluded if it's absent. I always look at the scalp very carefully since that's typically where children get their tick bites. And then we'll also ask about exposure to live or dead rabbits or squirrels and consumption of poorly cooked game meat. That is what the organism looks like in the upper right. And you can see it grows quite readily on this chocolate agar. And the tendency, as I mentioned, is for the microbiologist to take the lid off and smell it. And so when we suspect tuleremia, we tell the laboratory and they seal the plate. They do not open it. This can be easily diagnosed with a titer, with a serologic titer. And by the time the child gets to us, it's usually 1 to 2 weeks into the course, because they're not severely ill with this, but they do have the lymph node that's continuing to increase in size. So it's easy to diagnose it. And I mentioned that culture is dangerous. So the treatment for this is also something that's unusual. It's gentamicin, which is an IV aminoglycoside. It's not used for many things anymore. It has potential to be nephrotoxic or toxic to the kidneys, but it is the drug of choice. There's limited other options. The ciprofloxacin is one. We use it only with mild disease and with informed consent, because it has a variety of different adverse events that go along with it. Doxycycline, which I told you to remember, tickborne, doxy. It can be used, but relapses are frequently reported, and you can see mortality with this particular organism. So lastly, we'll talk about Lyme disease. And why do I want to talk about that? When you look here and you notice that it is primarily in the upper Midwest and the Northeast. The few cases that you see in Missouri are people who were from Missouri but traveled to the Northeast, and that's where they got their tick bite. But the CDC's convention is to report where they live currently, not where they acquired the tick. So very, very common in those parts of the country. It is the most common tick-borne disease of all. There is a tick-borne disease that looks like Lyme disease, but isn't, and it's called starry. It's a southern tick-associated tick-borne infection, and it produces the same skin lesion that makes you think about Lyme disease, but in this case, no one had visited those sites. So this is what it looks like. 3 to 30 days after a tick bite, you have a bullseye lesion. And one of the things that you'll notice about each of the pictures that I've shown you is that it is large. It is not a little reaction around a tick site, which is very common. It is an expanding lesion. So over time, it gets larger, larger, and larger. You have to be very careful in looking at the skin of someone whose skin complexion is darker, because you may miss this skin lesion. In many cases, you'll see a single lesion. In some cases, you'll see multiple lesions. So that is the early manifestation. And it turns out more than 90% of individuals have that skin lesion. It is easy to see. It is easy to diagnose. If you are from a Lyme endemic area, the diagnosis is made very promptly. If the diagnosis is made and the drug of choice, which is usually amoxicillin, which is a very common antibiotic, there are no late stage manifestations of this infection. It is treated, it is done. If it's missed, there are multiple different types of infections, manifestations that you can see. One is arthritis. And when this was initially reported in Lyme, Connecticut, it was reported because there was an outbreak of knee arthritis in school-age kids, and they finally tracked it back to this agent. It can produce heart block. It can produce facial palsy. And we saw a child, a teenager who went to camp in the Northeast part of the country, came back a month later with Bell's palsy, and it's very clear what his diagnosis was. In those particular cases, in these later cases, doxycycline is the drug of choice. Testing is problematic. There are all types of quack testing that are done around the country in laboratories that ask you to pay up front and that never have a negative test. And so the CDC is quite explicit that you have to have an exposure to an endemic area. You have to have a compatible presentation. And then it's a 2-step test that's done before the diagnosis is confirmed. It is the only tick-borne infection where we can give a single dose of doxycycline to prevent infection, but we do it only in select cases. The reason that tuleremia, Rocky Mountain spotted fever, and Erlichiosis are not on this list is they have shorter incubation periods, and what you might do is partially treat them and have an adverse outcome because the presentation is different. So because of the long incubation period with Lyme, if there is an engorged blackleg tick that's been removed, so it has to be engorged, it has to be present there at least 24 hours, and you can start doxycycline, the single dose, within 72 hours of tick removal, you may give a single dose for prevention. Now, even in tick-borne areas where they are Lyme endemic, only about 60% of those who have a tick bite are a candidate for prophylaxis. So it's, and as I mentioned, it's not recommended for the other tick-borne diseases. So the risk factors living in grassy, brushy, or wooded areas are around animals, spending time outside walking your dog, camping, gardening, or hunting. And as I mentioned, many get tick bites in their backyard. So we recommend insect repellents that contain DEET, and that it is safe. You have to apply it. You have to reapply it depending on how long you're out there. We make sure that dogs and cats are treated prophylactically. We recommend a daily tick check if you're out camping or if you're just in an area where you may be tick exposed. And remember, if you can remove that tick for the more deadly diseases, I will say, within 12 to 24 hours, you'll prevent transmission. And most people say, you know, you should shower as soon as you get back inside. It gives you the chance to do your best tick check. So that's the last one. The one thing I'll tell you is there are a lot of wrong ways to remove a tick. You have to use tweezers, you have to get to the base, and you have to use gentle pressure. No matches with smoke, no oil on the tick. None of that. So identifying if you have a tick, removing it properly, and hopefully we'll all stay safe from ticks this spring and summer. So thank you for your attention.
Thank you.
Yes.
So what happens if you're allergic to doxycycline?
It is a problem. There are hardly any people who are allergic to doxycycline. There's some, because
Actually, you probably need
No,
this,
no, she has the microphone on.
but she doesn't have it with her.
now I do.
For the
So,
folks in the on the street.
Almost any antibiotic, we can desensitize you if you have had anaphylaxis, but anaphylaxis with doxycycline is quite unusual. Where it really becomes a dilemma is Rocky Mountain spotted fever in a pregnant woman. I mean, it can be deadly, and then, you know, we still recommend doxycycline. A single exposure hopefully is fine for the unborn fetus. There's a little bit of data on rifampin, which is another antibiotic that's not used for many things. But for the most part, I will tell you in 40 years, and I can't tell you how many cases that I've used doxycycline, I've never seen an anaphylactic reaction. I've seen other kinds of reactions with it.
Hives?
Pardon me?
Like hives?
I've never seen, I can tell you I've not seen hives. When we give it IV, it is irritating to veins. And so for children and adults who are not vomiting and otherwise alert so they can swallow pills, we give it by mouth. And the only problem with giving it by mouth is teenagers in particular want to just pop it without water and not drink it, and it causes a terrible pill esophagitis if it's not fully swallowed with at least 8 ounces of water. So we would probably desensitize in an individual who had true anaphylaxis, because otherwise, you know, the outcome is not good.
That's good to know, because I'm allergic to a lot of antibiotics. So that's something that.
So there
And
are
always consider.
individuals who have multiple antibiotic allergy presentations, and we're getting better and better at testing and clarifying which ones are true and which ones are not true. Other questions? do you feel prepared to go out into the weeds now? And not to chase golf balls if you're a golfer? I hope.
Stay away from these.
Don't start golfing.
Thank you all.
Thank you.
Thank you.